right, we're moving along today in this conference, and just want to make a correction to that last talk. All of the vascular surgeons are friendly, not mostly friendly, just friendly. So we appreciate the continued support in this program. We still have over 130 people that are signed in and actively participating, and questions are coming. So we'll get to those in a few minutes. But it's my pleasure to introduce the next section, which is going to be our cardiac section. When we talk about PAD, CAD is so closely related. We know that in the PAD populations, especially in primary care, if they have PAD, half have CAD. And so we got to discover that and figure out who they are, and so that we can affect them and save them when we need to. So the next section is going to be, the first talk is going to be the starving heart. This is modern interventional coronary care by Selleck Tumble. He is a cardiologist in town. He's from the New York College of Osteopathic Medicine, and did some of his work at the Medical College of Virginia and affiliated hospitals in Richmond. Currently he's in the diagnostic cardiology group, works at Park Ridge hospitals, and also works at the CHI hospitals. He is board certified in internal medicine and cardiovascular disease, and a fellow of the American College of Cardiology. The topic after that is called the broken heart, and this is putting the pieces together. And Matt Wiesenin heralds from University of Minnesota, internal medicine residency at Mayo. He has fellowship at Kentucky in cardiology, interventional cardiology, and structural vascular care. And so he's going to talk about fixing the broken heart. The next talk will be Dr. Harish Maniam, who is currently the assistant professor at Erlanger Heart and Lung Center. He is the director of cardiovascular care there, and comes from Case Western Reserve, a great place, great institution. He's involved in multiple research trials, and his passion is atrial fibrillation. He's the guy for that, and optimizing programming options for patients with biventricular defibrillators, and then dealing with lead extraction and those problems. And then lastly, but not least, Allison Bailey. I think we'll enjoy her talks as well. She's from the University of Kentucky, and she is going to be talking about the failing heart. One of her passions in life is taking care of people with heart failure, and she is a cardiologist, fellowship trained. She has started a new group, Centennial Heart, at Park Ridge Hospital, and she's the director of cardiovascular services there. And she'll be talking about problems with advanced heart failure, transplant cardiology, adult echocardiography, and general cardiovascular disease. And so I'm looking forward to this session. It's always interesting to see what our cardiologists are doing to keep us alive. Number one killer in the United States is cardiac death, and this is going to be important. So without further ado, let's move on to cardiology.
All right, well, hello, everybody. Welcome to the segment Starving Heart. It's a privilege to be invited here to speak to you all, and hope you're having a meaningful virtual experience. I'm Selleck Tumble, private practice cardiologist here in Chattanooga. Again, thanks for inviting me to participate. But basically, we've got a short time segment, and some disclosures I have are I do speak for Janssen Pharmaceuticals and Amgen as well. So let's get started. So again, the starving heart, modern interventional coronary care. Well, if anything, the take-home message from today is avoid coronary artery disease, okay? And you won't have to face any of these things. The risk factors for coronary disease are relatively unchanged. Age, sex, hypertension, hyperlipidemia, diabetes, smoking, obesity, relative physical inactivity. We're all familiar with this, but you're going to say you heard it here first in Chattanooga, the latest and greatest risk factor. Here's the announcement. The novel CAD and vascular risk factor is, of course, the novel coronavirus, COVID-19, wreaking havoc on venous and arterial systems with little discretion, young and old alike. Okay, we'll get back to that momentarily. So coronary intervention has to be effective and safe. There's a lot of things available nowadays. Transradial approach, of course, is a hot topic, and Most patients are seeking that out nowadays just for comfort. But of course, the patients are increasingly complex due to multiple comorbidities, not the least of which is obesity. And of course, the transradial approach helps in those folks. But what happens if you get a stent? If you have a PCI, well, you are destined to take dual antiplatelet therapy for 12 months uninterrupted. So that means a lot of your elective procedures are just going to have to wait, and could get worse and result in a more urgent approach to these matters. And of course, bleeding risk is way up there. And some patients are designated to have high bleeding risk. Okay, that's based on age, history of bleeding, or taking blood thinners. It seems like everyone's on a blood thinner these days. Now back to the cath lab. How do we reduce the bleeding risks? Well, can we shorten the duration of the dual antiplatelet therapy? Well, we can now with the Medtronic Resolute Onyx stent. Okay, this is the first stent cleared by the FDA to reduce the duration of dual antiplatelet therapy to just 1 month for your high bleeding risk patients. So that's exciting news. What about heavily calcified lesions? These are increasingly complex. They usually are treated with a high pressure balloon, results in fracturing of this capped off lesion, and it's an uncontrolled process. And then once you open up the lumen, you need a nice landing spot for the stent. It's usually very irregular in there, and a lot of times the calcium can deform the stent and make life miserable for the interventionalist. Well, intravascular lithotripsy has been shown to safely treat severely calcified coronary lesions with the Shockwave IVL system, and basically it causes it fractures problematic calcium using sonic pressure waves in order to facilitate stent delivery and give you a nice area of deployment for optimal expansion, because we know if you don't expand that stent optimally, then you have a high risk of in-stent thrombosis and possibly death. Okay, so this will help improve blood flow to the heart muscle right there. What about more on COVID-19? Well, 10 to 15% of these folks wind up in our ICUs with severe respiratory complications, not the least of which, of course, is pneumonia, but of course, massive pulmonary embolism. And they can secondarily or primarily develop cardiac complications as well. A lot of times the heart's an innocent bystander. We get problems with like cor pulmonale and things like that from hemodynamic derangements resulting from a massive pulmonary embolism. But you can, and this can lead to heart failure, very typically diastolic, and that helps contribute negatively toward the patient's hypoxemia, which is a hallmark of these really sick patients. And now the heart can directly be affected as well by the virus, with resulting in myocarditis and all of its problems. Of course, myocarditis can lead to just resistant arrhythmias, congestive heart failure, and just increase the morbidity and mortality of your patients. Okay, but blood clots is the concern with this disease, and it's really rather indiscriminate. It can be systemic in the venous system, arterial system, or both. Patients are coming in through the emergency room, and they're risk stratified with a lot of these markers, including troponin measurements and other inflammatory markers, and they need to be pursued. In the past, we might just describe the elevated troponin to strain or enzyme leak, but now we've got to be concerned about just thrombi forming in the arteries. Just had a 40-year-old come in the other day with peak T waves and chest pain and elevated troponin, positive COVID. And lo and behold, his right coronary artery had an occlusion in one of its major branches. Now, with hemodynamic derangements, of course, these patients have developed progressive hypoxemia, and ECMO is increasingly utilized with these patients. But also there's the Impella device, which is an intraventricular cardiac output booster, basically, that's placed percutaneously. And Abiomed is the company that has the Impella device. They've combined their Impella device with ECMO, and they've developed something called the ECPella device, where the hypoxemia is relieved by the ECMO component, and the Impella is placed either in the right ventricle, the left ventricle, or both, to help improve cardiac performance and improve hemodynamic parameters. Okay, one of the more famous problems in the cath lab is the oculostenotic reflex. Okay, this is described as basically iatrogenesis fulminans. Okay, uh, show a series of coronary angiograms to 10 different doctors, you might get 10 different opinions. Not the least of which are the moderate grade lesions. What to do with those? Moderate meaning less than 70% severity. We need quantification to help determine which lesions are best treated with either bypass or stent. FFR is a fractional flow reserve measurement. It requires placement of a pressure wire down the artery across the lesion, and then a hyperemic effect with adenosine to help give you calculate the FFR number, which basically, if it's above 0.8, it's doesn't require a stent, and below that it will. But what do you do with these lesions when you have a negative result? You're still left with this moderate grade lesion that worried you enough to take the extra step with the FFR. Well, we've got IFR now available, and also and then there are some non-invasive techniques that will be coming out. They just need to be studied in with larger patient numbers to demonstrate the validity. But the FFR CT and OCT as well for 3D reconstruction using optical techniques to determine what lesions are hemodynamically significant or not. So if you have a negative FFR and you're left with a lesion, you can feel good about further quantification or risk stratification using these elements. And can you imagine doing an angiogram where you inject the coronary and automatically you have this technology integrated into your angiogram imaging, and you get not only the image, but you get the quantification of the hemodynamic derangement there, and determine whether proceeding ahead with revascularization is the right thing to do. So that will be very helpful with decision making in the cath lab. It likely will reduce the need for procedures and unnecessary referrals for bypass surgery even. Well, thank you very much, and I hope that was somewhat helpful for bringing you up to date some of the techniques we have. I think we're still learning, of course, about the COVID-19 effects. More than a virus, it's a real threat to the venous and arterial systems, and just in anybody walking in the door. And I have to think increasingly antithrombotic therapy is going to be a major arm of treatment of this virus, in addition to some of the other anti-inflammatory measures. Anyway, enjoy the rest of your conference, and look forward to meeting with you again in the future. Thank you.
Hi, my name is Matt Wiesen, and I'm the Director of Structural Heart Services at Erlanger, and next year we'll be over at Park Ridge as the Structural Heart Director and Cath Lab Director over there. Today we're talking about the broken heart, putting the pieces together. And what does that specifically mean? Well, we're going to talk about structural interventions. So what are structural interventions? What is the heart team approach to cardiac care? What are some of the prototypic disease states that we treat in the structural space, including valvular heart disease and other structural defects? And we're going to finish it by talking about left atrial appendage interventions. Structural heart interventions are really procedures that are intended to repair or replace defective structures within the heart that are not the coronary arteries. So this includes valvular heart disease, this includes congenital and acquired structural abnormalities of the heart, and also we'll talk a little bit about the left atrial appendage as well. Structural interventions are not intended to put cardiac surgeons out of business. Rather, they're intended to bring all specialists, cardiac surgeons, general cardiologists, and interventionalists together to figure out what the best treatment strategies are for patients, given the number of options that we have available to us today. The prototypic structural heart intervention here for us is the TAVR. So this really is something that started for us back in 2012. where on the left-hand side of the screen you have a normal aortic valve, and on the right-hand side of the screen you have a stenotic aortic valve. And this was a problem where we were not adequately treating a number of patients because they were too old or sick. In looking at what causes aortic stenosis, bicuspid aortic valve disease, unicuspid aortic valve disease, and then trileaflet aortic valve disease is the most common one. So trileaflet being degenerative and calcified, that's what we see most commonly. Rarely we see rheumatic heart disease. But when we look at how this has traditionally been treated, it had been treated primarily with open heart surgery and a valve replacement. But nowadays, we can do these usually percutaneously through a femoral artery approach, where we come from usually a patient's femoral artery, bringing the new valve up into the aorta, around the aortic arch, and then we come up to the level of the aortic valve, and we can push the aortic valve, the native aortic valve tissues off to the side, bringing in the new aortic bioprosthesis. The image on the right side is the Medtronic self-expanding stent system, and on the left side is the Edwards Sapien, which is a balloon expandable system. So on the right-hand side of the screen, you can see that the self-expanding nitinol frame with a new valve sewn on the inside simply is unfurled, and as it expands, it pushes the native leaflets off to the side and has its new leaflets positioned inside and begins to function immediately. On the left-hand side of the screen, you can see that after we do the fine-tune adjusting for the position of the new aortic valve, we can rapidly pace the heart at 180 beats per minute, and then we can inflate the balloon, deploying the new aortic valve into the position that we want, pushing the native leaflets off to the side. And now once the balloon is deflated, the new valve begins to function immediately. What this has, the process this has gone through to get to where we are today is we started in really old and sick patients who were too sick for open heart surgery and showed significant morbidity and mortality benefit there. We then proceeded to high-risk surgical patients, intermediate surgical risk patients, and low-risk surgical patients, all showing that equivalent outcomes could be achieved both through a transcatheter and a surgical approach. So now, the current state of TAVR is that we can typically default to a transcatheter approach after the patients have been through the heart team and seen both the interventional cardiologist and the cardiac surgeon, and will default to TAVR unless there's another reason for that patient to go to open heart surgery. We're also thinking about what does it mean for the lifetime of these patients as they're getting younger and healthier. These valves are typically only lasting about 10 years, so what are you going to do in 10 years when you have to go and replace your replaced valve? So do you start with the surgery first? Do you do a transcatheter valve procedure first? And how do you progress from there? And those are all things that are still being worked on. Most of our procedures these days are done with conscious sedation. Most are done percutaneously. Most of our patients are ambulatory within 6 hours, and most go home the very next day. Moving on to mitral regurgitation, this is a problem where you have leakage of your mitral valve from the left ventricle back into the left atrium, as what you can see on the right-hand side of the screen. Mitral regurgitation really comes in two varieties. One is from an overabundance of mitral tissue that is either prolapsing or flailing across one of the other leaflets, leading to the regurgitation. And the other is functional, where you have a dilated LV and you have stretching of the annulus of the mitral valve, leading to the leaflets not meeting in the middle and coapting well. Surgery has always been a very good option for patients with myxomatous degenerative mitral valve disease with a good repair. That's always a good long-term result. But functional MR and heart failure patients really have not done well with surgery in the past. And so we thought medical therapy was the best until the publication of this pivotal clinical trial a few years ago called the COAPT trial, showing that patients with bad heart failure who were on good medical therapy, if they had bad mitral regurgitation, actually benefited in getting a clip to tether the leaflets of the valve together and reduce the mitral regurgitation. So you can see a dramatic reduction in heart failure hospitalizations, as well as a dramatic improvement in overall mortality, with a number needed to treat of 6 patients to save 1 life with this MitraClip procedure. So what does this look like? So on the left-hand side of the screen, we see color Doppler imaging of the severe regurgitation going back across the mitral valve from the left ventricle to the left atrium. And on the right-hand side of the screen, we see the 3D images showing the prolapse of the mitral valve causing this particular patient's problem. We can then bring a 25 French catheter up from the femoral vein across the interatrial septum and into the left atrium and position a clip within the left atrium, align it in the lower right-hand side of the screen with where we want to go on the mitral valve. And then what we can do is we can bring this clip down across the mitral valve, position it to where the biggest problem for the leakage exists, and now we can tether that part of the leaflet together by bringing this clip in and bringing those two pieces together and substantially reducing the amount of leak in that mitral valve. This is what it looks like under fluoroscopy, where you have the clip being deployed and released on that mitral valve. Again, most of the imaging is done using echo, and you can see the echo images on the left-hand side with the clip in place show a substantial reduction in this patient's regurgitation. And on the right-hand side of the screen, these are the TEE images. The first is the 3D image showing what I lovingly refer to as the bow tie sign. And then the second image is showing that you have very little leakage or regurgitation left, which is a very good result for this patient. So these clip procedures, mitral clip procedures, are currently done for high-risk patients with degenerative mitral valve disease and for most patients with functional mitral regurgitation who are on really good heart failure therapy but still have really bad MR as a result. The heart team assessment includes the interventionalist, the cardiac surgeon, and a heart failure specialist to make sure we're doing the right things for these patients. Patients are typically up and walking in about 6 hours after the procedure, and most are going home the very next day. Moving on to atrial septal defects and patent foramen ovales, we know that a PFO, or a patent foramen ovale, is associated in some patients with a cryptogenic stroke, meaning that if you had a cryptogenic stroke and a PFO, you were more likely to have a recurrent stroke on down the road. This trial, called the RESPECT trial a few years ago, showed that by closing the PFO, you could reduce the risk of recurrent strokes. And so this device has subsequently been FDA approved for reducing the risk of subsequent strokes at a very low risk of procedural complications. So what does this look like? Well, again, we come from a femoral venous approach and we cross over the interatrial septum. Once we cross the septum, we can bring out the left side of the device in the left atrium. This is a nitinol disc that goes up against the interatrial septum. We then can deploy the right-sided disc, and this essentially sandwiches the defect. Once we release the device, then it endothelializes over the next several weeks to months. And this, again, is what leads to a decrease in the recurrence of recurrent stroke. So again, this is an echo study showing that once the bubbles get injected, there's a big shunt of bubbles across, meaning this patient likely has a PFO. These are the intracardiac echo images showing that a lot of bubbles in the upper left-hand side of the screen are crossing over, a lot of color flow going from right to left on the upper right-hand side of the screen. In the lower left-hand side of the screen, the device is being deployed, and once it's released in the lower right-hand side of the screen, we can see that there are no bubbles crossing over at that time. We are closing PFOs for patients with cryptogenic stroke and paradoxical embolism who also have a PFO. We are closing these for scuba divers and those who have abnormal shunting leading to hypoxemia. We're also closing ASDs in a very similar fashion. These are all done with conscious sedation. Patients are ambulatory in about 4 hours, and they all go home the very same day. Moving on to our final topic here, which is left atrial appendage occlusion. This was a procedure that was approved in 2015 as an alternative to oral anticoagulation for stroke prophylaxis in patients with atrial fibrillation. The Watchman device is currently the only device that's FDA approved for this, and this was proven in a number of trials, including the PROTECT AF and PREVAIL trials, showing that you had a non-inferiority outcome to oral anticoagulation for stroke prophylaxis, but you had a significant reduction in bleeding events, which led to an improvement in all-cause mortality as a result. So what we see here is a very standard TEE image on the left-hand side showing us the appendage where these clots form in atrial fibrillation. On the right-hand side is the angiographic picture, what I call the appendageogram. In the left-hand side of the screen here, we see the Watchman device, this plug being deployed in the left atrial appendage under fluoroscopic visualization. We see the device then under TEE visualization, where we can reposition it or we can move it if we don't like it. And then we finally finish with a repeat angiogram showing a nice seal of the appendage, and we can show the final TEE image once the device is deployed. This is again a percutaneous access, 4 hours of bed rest. The patients are going home the next day. They will stay on their blood thinner for 45 days, but then go on dual antiplatelet therapy for 6 months, and then aspirin monotherapy for life. Other procedures that are done in the structural heart space include ventricular septal defect closures, paravalvular leak repairs, patent ductus arteriosus closures, coarctation repairs, alcohol septal ablations for hypertrophic cardiomyopathies, vacuum-assisted right atrial mass extractions for tumors and endocarditis vegetations, and then other tricuspid and pulmonic valve therapies, and soon to be coming to the forefront, percutaneous mitral and tricuspid valve replacements that are still in clinical trials. To summarize, this is a rapidly evolving field where we have advanced training for all of the providers involved. It requires a good heart team approach where everybody comes together and collaborates on behalf of the patient, checking their egos at the door and only thinking about the things that are going to benefit our patients. We also have to be involved in clinical trials and ongoing registries for ongoing assessment of the quality of our program. And with that, I thank you for your time.
Hello, good afternoon, everyone. Thanks for joining us today in my presentation on the electrical heart, a shocking experience. My name is Dr. Harish Maniam, Chief of Cardiology and Co-Director of Erlanger Heart and Lung Institute. So what is sudden cardiac death? When we think about it, do we think about the picture on the left where you see someone who's been in a car crash versus someone who's been in a shooting? Both of them, you have EMS personnel at the scene, but clearly the car crash, you wonder, did the officer pass out here or did they actually hit something? And so that could be a potential cardiac arrest, and actually very similar to the cases that we often see here at Erlanger. And so when we think about sudden cardiac death, it's really the sudden loss of blood circulation, and it's the failure of the heart to contract effectively, which is really related to this rhythm, which is ventricular fibrillation. And so sudden cardiac death, when we really divide it, you have to be somewhat biased in thinking about patients when they come in, because sometimes they can't give you a history. And so we think about patients that are less than 35 years of age, the most common cause is hypertrophic cardiomyopathy. Patients above the age of 35, more often than not, is really related to coronary disease, which is myocardial infarction. Causes of sudden cardiac death in general: long QT syndrome, hypertrophic cardiomyopathy, Brugada syndrome, acute MI, catecholaminergic polymorphic ventricular tachycardia, arrhythmogenic right ventricular cardiomyopathy, and Wolff-Parkinson-White syndrome. We're going to touch on all of these. So long QT recognition, when we look at this, there's different patterns that can help us diagnose really the genotype of the patient. So you look at long QT, not only do they have a long QT, but they have a long QT that sometimes is in normal proportions, and that's really long QT1. This is really related to a decrease in the potassium channel. Long QT2, you see a bifid notched T wave, and then long QT3, you really see this long isoelectric segment for the QT interval. When you think about the triggers for long QT1, it's really exercise induced. Long QT2 really related to sleeping and sometimes emotion. And then long QT3 really related to patients that are sleeping. So when we think about when do we find these patients for long QT1, a lot of the time it's swimming. So someone jumps in the pool, they're exercising, and then they have a cardiac arrest. Then long QT2, they have some kind of auditory stimulus, something that wakes them up, and then all of a sudden they have a cardiac arrest. So that clinical history can help also in diagnosing their genotype-phenotype correlations. So overall, the patients that are worse is the patients who have a longer QT interval. So the longer the QT interval, the worse the patient does. And so definitely over 500 milliseconds, we really see a lower survival rate with those patients. So the management of these patients, we want to put all these patients on beta blockers, which is really the therapy. And obviously acutely, if they have VT, VF, we want to actually shock them. Chronic therapy, keep them on beta blockers. We have to think about ICDs in this patient. So if they died, then we have to put a defibrillator in. If they've had a spell where they're passing out and they're on a beta blocker, then that means they had cardiac arrest on therapy, and then we would put a defibrillator in. Anyone age less than 5 with syncope, we would put a defibrillator in. Very long QTs have a higher probability of dying, which we showed. Those patients would need an ICD, and males who actually have long QT3 have a higher chance of dying. So we would put an ICD in these patients. And then in some cases, they continue to have VT or VF with an ICD and beta blocker therapy. We have to think about a sympathectomy. The genotype specific therapies for long QT1, beta blockers, long QT2, beta blockers, long QT3, beta blockers. But really, in long QT2, we can also treat them with potassium or a potassium sparing diuretic such as aldactone. Long QT3, treating them with mexiletine and flecainide. So we have some pediatric patients that are on these therapies. Acquired long QT syndrome, some of these patients actually have long QT and result to medications that we put them on, drugs. They have some kind of ischemic heart disease, chronic heart disease, electrolyte abnormalities, and intracranial abnormalities. So really you have to treat those underlying causes. But in addition to treating the underlying causes, you also have to assess whether or not they do have a genotype that's related to that, because most patients who have some of these drugs or ischemia don't necessarily have long QT at baseline. So making sure that they have a genetic test for long QT is still important. So this is an example of a patient who has Brugada syndrome. So you really see these QRS complexes with this ST segment that looks like you're standing on the top of a black hill diamond looking right down. And when you see that, that's very classic of Brugada syndrome. And so Brugada syndrome, really we can get sudden death due to ventricular fibrillation, much more common in men. We do have Brugada syndrome in the Chattanooga region. It's more prevalent in the South Asian population related to this J point elevation that I showed you on this prior EKG. And it is made worse by sodium channel blockers and beta blockers. So treating them with these can make them much worse. It's improved by isopril, so someone who has incessant ventricular fibrillation or ventricular tachycardia with Brugada syndrome, isopril would be a treatment and exercise. And these are patients that actually sudden cardiac death or syncopal events can be provoked by fever. So if you have someone who has a fever and all of a sudden passes out or has a VT or VF event, you have to evaluate whether or not Brugada syndrome was the result. So symptoms in these patients, obviously asymptomatic Brugada patients, we don't need to worry about, but patients who have syncopal events or obviously sudden cardiac death events have a higher chance of dying. So therapy, acutely, obviously defibrillation, if they continue to have VT-VF, we got to think about isopril, and definitively they do need defibrillators. So potential therapy for patients who have Brugada, and this is a patient who had epicardial access where we put a needle through the pericardial space through the chest and actually electrically map areas that are causing Brugada syndrome and able to ablate or burn the epicardial surface of the heart to actually change the repolarization abnormality here. And actually these STs go back to close to normal here once you ablate them. We look at this patient, this is an example of obviously another example of ventricular tachycardia, but you can see here that this is what's called bidirectional ventricular tachycardia, only present in really two conditions. One is DIG toxicity, the other one is catecholaminergic polymorphic ventricular tachycardia. So this is related to a mutation in the ryanodine receptor. It causes really leaky calcium channels. And what you see is usually during exercise or stress test that as patients start exercising, that you see more PVCs, and then they have runs of ventricular tachycardia, and then you have them stop. The acute treatment obviously is defibrillation, but the key for these patients is actually beta blockers. So suppressing or decreasing the sympathetic output for these patients is important. You can sometimes sedate them if they continue to have VT or VF. Definitive treatment, we need to keep them on beta blockers. Actually, flecainide is a great medication for them. And we have to be cautious about using ICDs for these patients. Obviously, if they've had sudden cardiac death, then we do put an ICD in. If they haven't, then trying to treat them with beta blockers and flecainide would be more appropriate at that point. Arrhythmogenic right ventricular dysplasia is this really thin-walled RV and really not formed well. In a lot of cases, we can see these inverted T waves here in the precordial leads. But in addition to that, we can see what's called an epsilon wave, which is seen here in V1. It is present in 1 out of 5,000 people of the general population. Men are more frequent than women. It's 11 to 22% of young population, 17% in the United States, and it's autosomal dominant. So if someone in the family has it, you have to expect that someone else in the family may have it. So common symptoms, palpitations, syncope, and obviously ventricular tachycardia. And it can be a lot of times biventricular in nature. So even though the nomenclature says right ventricular, it could be both sides. So the diagnosis of this is related to multiple different things, but right ventricular akinesis and dilatation or decreased ejection fraction, see a myocyte loss with fibrosis, repolarization changes in epsilon wave, which we saw in the EKG that I presented, arrhythmias, which are related in a left bundle-like format, and a family history, obviously, with an autosomal dominant pattern. And so we do see a lot of these patients who get diagnosis and have events actually just at home. So not necessarily doing anything specific, but generally just sitting at home. And so for these patients, we do exercise, restrict them. So that's very important. Put them on beta blockers. Think about ablating their VT, which is usually seen over this right ventricular epicardial space, and ICDs for patients who have VT. So we do see that patients who do have endocardial alone, meaning we put ablation catheters inside their heart, they don't do as well as those that have ablations that are inside and outside their heart to prevent this from reoccurring. And this is kind of how we approach a epicardial ablation outside the heart sac. And so this is obviously a pathological slide. And so we're inserting a needle. The needle goes into the pericardial sac, the sac outside the heart. And you can see some tenting here of that sac. And then we thread an ablation catheter outside the heart here. So syncope in athletes, this is EKG of obviously someone who has very, very big QRS complexes, really deep T waves. So very classic of this picture, which is called hypertrophic cardiomyopathy. And this is a MRI picture. You see a very, very thick muscle here. And this is actually the blood pool. So very tiny, almost like a spade. And then here, this is a pathological specimen with very, very thick left ventricular wall muscle. And so hypertrophic cardiomyopathy, very, very common for sudden cardiac death in patients who are less than 35 years of age. Complaints of exertional syncope, pulmonary congestion, chest pain, and palpitations. Diagnosis can be made on EKG, echo, and MRI, and is the most common cause of sudden cardiac death in young athletes. So it's very, very important to remember. 1 to 2% annual mortality. The treatment acutely is obviously defibrillation and CPR. Also acutely, you can give them phenylephrine, which actually is a selective alpha-1 agonist. Definitively, they'll need an ICD, beta blockers, calcium channel blockers, slow down their heart rate, improve the diastolic filling time. You can also use a septal ablation, so we can kill some of this muscle, so the amount of blood that can get in here is increased, or we can actually do a septal myectomy and actually shave off a piece of this muscle. And so risk factors for these patients: family history of having hypertrophic cardiomyopathy, failure to raise their blood pressure with exercise, if they have a really thick LV muscle greater than 30 millimeters, if they have a history of non-sustained VT or syncope, these are patients we have to think about putting a defibrillator in. It's another example of a patient who has ventricular tachycardia, but when you really look at it, what's abnormal about this? This is an irregular example of maybe VT, but it's really not VT. This is actually WPW. And so this is a patient who has atrial fibrillation and WPW. And what's happening here is that they're going 350 to 400 beats per minute here in the atrium. And that 350 to 400 beats per minute usually goes down the AV node. The AV node blocks about half of those. And so really you see usually 140 to 170 down here in the ventricle. But when you have this WPW or an extra circuit, it bypasses the AV node and it's able to go unchecked down that circuit, so that 350 beats per minute in the atrium now becomes 350 to 400 beats in the ventricle, which is really VT or VF. And so patients have palpitations, dizziness, syncope, sometimes anxiety, very common, 1 to 3 out of 1,000 patients, men more common than women. You could do EKG, a heart monitor, and EP testing to evaluate these patients. And so this is just a basic EP study on someone. We put atrial catheter here, put our HIS catheter here looking kind of at the AV node. And then we put an RV catheter here. So we're able to get different signals from the heart, and they correlate with surface, basically our surface EKG. P waves correlate with our high right atrium. Our QRS complexes correlate with our RV catheter. And so acute treatment for these patients who are in AFib with WPW is actually you want to defibrillate them, and procainamide would be a good actually medication to give them. Definitively, they will need an EP study and ablation, as AV nodal blockers can make them much worse. This is a 47-year-old with syncope, and so also again VT, but we also see that there's ST elevations. And so these ST elevations are related to acute MI. Obviously, the most common cause of sudden cardiac death in patients over the age of 35, chest pain, shortness of breath, and palpitations, diagnosis with EKG enzymes and symptoms. The acute treatment is CPR, defibrillation, amiodarone. We think about Mona, morphine, oxygen nitrates, and aspirin. Definitive treatment. We want to open the artery. So you see a closed artery here, open artery here. The real question is, do they need an ICD? Probably not if you open up the artery. In the last case, 87-year-old with chest pain, you see ST elevation MI, but what else do we see? You see actually complete heart block. You see P waves without any association with the QRSs. So most common with an inferior MI. But here you have presentation with syncope, fatigue, dizziness, and chest pain. Diagnosis based on EKG and exercise stress tests in some cases. Acute treatment, atropine, pacing, dopamine, isoprel to speed up the heart rate, transvenous pacing. Obviously, we want to assess for an acute MI. And definitively, those patients will need a pacemaker. Thank you very much for your time.
Hello, my name is Allison Bailey, and I'm a cardiologist at Centennial Heart at Park Ridge, and I specialize in heart failure. I'm so glad to be here today for the 3rd annual Faces of PED conference to talk to you about heart failure and the failing heart. I thought I would start us out by a case. Whenever I think about a patient coming in to see me in the clinic, I always think about it case-based. So this patient's a 70-year-old female who comes in with increasing dyspnea on exertion. When we meet the patient, we see that she has a past medical history of hypertension, non-obstructive coronary artery disease, stable peripheral arterial disease, type 2 diabetes, and obesity. And really her complaints have been progressive DOE. On exam, we see elevated jugular venous pressure to mid-neck sitting on her exam table. She has a regular rhythm with a 2/6 early systolic murmur that you hear at both the right and left upper sternal border. She still has preservation of S1 and S2. Her radial pulses are normal without delay. She does have crackles bilaterally and 1+ pitting edema to her knees. She has warm extremities with diminished but still palpable peripheral pulses. So when I see this patient, what I start with is the clinical diagnosis. What is my clinical thought? And my clinical thought is this patient has heart failure. She has evidence of elevated cardiac filling pressures by essence of elevated jugular venous pressure, and she has pitting edema, and she has symptoms consistent with heart failure. She has dyspnea on exertion. So after I've made this clinical diagnosis, then I'm looking for other tools to help me figure out what's the best way to treat the patient. And that's really where the echocardiogram comes in. So the first thing I want to know on the echo is what is her ejection fraction? And we'll talk more about the types of heart failure, but that will better allow me to optimize her treatment. And then I want to know what's the role valvular heart disease may be playing here since I heard a murmur. So I send her off for an echo, and it shows moderate left atrial enlargement, which is abnormal in an elderly patient complaining of dyspnea, moderate left ventricular hypertrophy. She has global hypokinesis with a moderately reduced EF of 30 to 35% and only mild aortic stenosis. So I've now put this patient into a category of heart failure with reduced ejection fraction, and that's diagnosed with an EF less than 40%, and it's what we've classically referred to as systolic heart failure. And again, heart failure is a clinical syndrome, which I've already diagnosed her with, that is an impairment of the ventricle's ability to either eject blood or both fill with blood and eject blood, and most commonly presents with symptoms of dyspnea and fatigue and the signs of lower extremity edema and elevated jugular venous pressure related to fluid retention. Now, the other type of heart failure is heart failure with preserved ejection fraction, and that really comes into category of more than 50% on echo, and this is what we frequently call diastolic heart failure. When we talk about these two types of heart failure, we should think of them both by pathophysiology and then by what does the heart look like. So when we talk about HFpEF or heart failure with preserved EF, I think of this as a thick, stiff ventricle that doesn't want to relax well. So when the ventricle is filling with blood from the left atrium, that is the part of the cardiac cycle that's impaired. And so when the heart rate goes up or when there's too much volume, those patients become very symptomatic and they get an elevated left ventricular end diastolic pressure, which results in left atrial enlargement, elevation in jugular pressure, and pulmonary edema, and eventually peripheral edema. If we think about HFrEF, or heart failure with reduced ejection fraction, the left ventricular pumping chamber itself is abnormal, and so the ability to eject blood is impaired. That usually happens from things like prior heart attacks, cardiotoxins, drugs, myocarditis that has affected the heart. But the end result is the same, an elevated left ventricular end diastolic pressure because we can't pump blood forward effectively, increased left atrial pressure, and resulting pulmonary edema. So the clinical syndrome is very similar for the two types of heart failure, but the treatment's quite different. And that's why it becomes important to know what we're dealing with. When we think about the risk factors and how commonly we see these two entities, we see them roughly about the same in the population. So this is a large outpatient registry, and what we see is that preserved or reduced EF occur at about 50% likelihood. And when we look at the risk factors, high blood pressure, coronary artery disease, and diabetes are among the most common. One other thing that we'll talk about with the epidemiology of heart failure is it becomes more common as we get older. And if we survive to age 55, we still have about a 30% lifetime risk of developing heart failure. HFrEF is seen more commonly in males, and HFpEF is seen much more commonly in females with almost a 2-to-1 likelihood. Heart failure is also a progressive disorder, which is very important. It goes from stage A, which is people with risk factors, which is basically anyone with hypertension, obesity, diabetes, using cardiotoxins, all the way over to stage D, which is refractory heart failure. Stage C is when we meet the majority of patients, and this is when you have structural heart disease and you have a first clinical episode of heart failure. Stage B is when you have episodes of structural heart disease, evidence of structural heart disease, but you've not yet had heart failure. So that may be left atrial enlargement or left ventricular hypertrophy on an echocardiogram. Stage C is where all of our medical treatments come into play, and we'll talk about that most extensively. But heart failure is progressive. So once you become a stage C, you can't go back to a stage B. And we'll contrast that to New York Heart Association classes. You can move back and forth between classes because that really describes our functional status. So a class 1 means you can do what activities you want to do without limitation. And a class 4 means symptoms at rest even. So a class 2 would be slight limitation with physical activity. A class 3 would be significant limitation of physical activity. So when someone comes into the hospital with a decompensation, they may be a class 3, but with fluid removal and treatment of blood pressure and heart rate, we may get them back to a class 1. So heart failure is progressive. Heart failure is also very common. It has a prevalence of about 6.5 million people living with heart failure in the United States and about 1 million new cases annually. It's very expensive. We spend over $30 billion for the cost, both direct and indirect, of heart failure. And when we look at outcomes, the prognosis is quite poor. So if we look at 5-year outcomes, HFrEF and HFpEF have a 5-year mortality approaching 75%. Readmissions to the hospital are also quite frequent. And so we look at a disease that is common, it has very common risk factors, and it affects a significant proportion of the population with a poor prognosis. So we have to be very aggressive at the treatment of this disorder. Now, I also try to tell people who are diagnosed with heart failure, especially young patients in 2020, we have a whole new armamentarium of medical treatment that we can provide. So hopefully our prognosis will change over the next 5 years. So let's just talk about stage A heart failure, and that's really those people at risk. And really the treatment here is prevention. So treat blood pressure to establish guidelines, less than 130/80. Treat lipids based on the AHA/ACC risk calculator and lipid guidelines. And then treat other disorders like hyperglycemia or diabetes. Try to get people more active and to lose weight and to avoid cardiotoxic substances. Once you get to stage B, or evidence of structural disease, then you would treat based on whatever that pre-existing condition was. If you've had a prior myocardial infarction, then perhaps you'd use a beta blocker. If you've had diabetes, you would use an ACE inhibitor. But once you get to stage C, that's really where we have the strongest evidence. And so stage C, again, is when you've had a symptomatic episode of heart failure. We'll start with the treatment of HFrEF, and that's an ejection fraction less than 40%, because this is where we have the majority of our data. So historically, the treatment has been an ACE inhibitor or an angiotensin receptor blocker and a guideline-directed beta blocker for all patients. And then those patients who have a GFR above 30 and a creatinine less than 5, addition of an aldosterone antagonist, spironolactone or eplerenone. For volume overloaded patient, we could add a loop diuretic. And then for persistently symptomatic patients who are self-described as African American, the addition of hydralazine or nitrates can reduce symptoms and improve outcomes. If we talk about ACE inhibitors, they offer multiple benefits for our HFrEF patient. And this is a meta-analysis that looks at the benefits across the class of ACE inhibitors. And we see consistently about a 20% reduction in mortality, as well as about a 30 to 35 risk reduction, relative risk reduction in hospitalization for heart failure. And again, ACE inhibitors we think of as being a class effect. ACE inhibitors have a common side effect of cough. So if a patient can't tolerate an ACE inhibitor because of a cough, we think of ARBs, angiotensin receptor blockers, as having a similar magnitude of benefit. Again, another meta-analysis looking at the benefits of ARBs in patients who can't tolerate ACEs and HFrEF. Once you have an ACE or an ARB, then beta blockers are the next class of medication we'll talk about. And these are not the entire class of beta blockers, but really 3 specific beta blockers: carvedilol, bisoprolol, and metoprolol succinate. And you can see in this combination of trials, we see significant risk reduction in mortality with beta blocker therapy, somewhere between 30 and 60% in these seminal trials looking at beta blocker therapy in patients with HFrEF. So again, ACE or ARB, beta blocker have been our mainstays of care. And then if we look at aldosterone antagonists, things like spironolactone or eplerenone, we can see about a 15 to 30% relative risk reduction in those patients with ejection fraction less than 40%. So those have been our 3 historic pillars of treatment for our heart failure population with HFrEF. I'll add one caveat about spironolactone or aldosterone antagonists. They're very underutilized in the United States, with only about 50% of patients that are eligible to receive the therapy currently receiving it. And one of the concerns is hyperkalemia and hypotension. So this was a nice analysis of one of the spironolactone trials, and it showed that even in those patients with an initial blood pressure less than 105 systolic, they tolerated aldosterone antagonism very well. So blood pressure is not a contraindication. Sort of our newest line of therapy came just a few years ago with the Paradigm trial. And that trial, enalapril, an ACE inhibitor, was compared to sacubitril valsartan and followed for long-term outcomes. Sacubitril is a neprilysin inhibitor, and it has multiple effects, including vasodilation. It lowers blood pressure, it reduces sympathetic tone, it improves natriuresis and diuresis. And when we studied those patients who were already getting other medical therapy with beta blockers, mineralocorticoid antagonists, and ACE inhibitors, we saw a significant reduction in the composite endpoint in this trial. Again, a HFrEF population, and we saw multiple benefits across multiple different patient subgroups in the trial. And when we compared the benefit in reduction in mortality to an ACE inhibitor or an ARB, we saw about a 20% relative reduction in mortality with an ARNI or an angiotensin receptor blocker neprilysin inhibitor. So since 2014, when this Paradigm trial came off, this has been a practice-changing drug in heart failure therapy. And in that trial, patients were started as an outpatient. And so the Pioneer trial was a proof of concept trial looking at starting patients in the hospital and proving safety of adding an ARNI at that point. And what we saw was that it was a safe strategy and was associated with improvements in brain natriuretic peptide or BNP levels when compared to enalapril as an outpatient. Now, there have been multiple analyses that compare reductions in BNP to reductions in clinical outcomes, and we'll be continuing to follow this. But currently, starting an ARNI in the hospital is considered a safe practice. Now, when we're talking about heart failure and drug therapy, doses matter. So when we start a patient on a dose, our goal should be to increase those doses every 2 to 4 weeks until we reach the maximum recommended dose or the patient no longer tolerates the therapy. And so the goal dose of lisinopril is 20 to 40 milligrams daily. The goal dose of carvedilol is 25 to 50 milligrams twice daily. And the goal dose of spironolactone is 25 milligrams daily. When we talk about prescription or the likelihood to prescribe all of the classes of medicines that benefit our heart failure population, we see that less than 1% of patients in the US were on optimal dosing of the medications known to improve HFrEF outcomes. So we've got some work to do. So this was an update to the heart failure guideline from 2017. And really what it says is that if we have a stable patient that's already on an ACE or an ARB, we should discontinue those and start an ARNI. And you do have to stop an ACE for 36 hours before initiating an ARNI. Make sure we have aldosterone antagonists, and then consider hydralazine and nitrate if needed. Now, since that time, we've had the 2 trials with SGLT2 inhibitors, which were medicines that were initially used for diabetes and the anti-hyperglycemic effect, but we saw about a 30 to 40% reduction in heart failure hospitalization. So dapagliflozin was studied in the DAPA-HF trial, looking at patients with heart failure and reduced EF with or without diabetes. And what we saw was about a 25% risk reduction in heart failure, worsening heart failure event or cardiovascular death. The Emperor Reduced trial just showed a similar benefit in empagliflozin, again in a HFrEF population. So starting now, there really are multiple pathways that we think these medicines benefit our heart failure patients, including reductions in preload and afterload, natriuresis and diuresis, as well as other mechanisms we're still studying. But if you look in 2020, I would tell you that we are in a new era in heart failure, and there's really 4 pillars of therapy: guideline-directed beta blocker, an ARNI, a mineralocorticoid antagonist, and an SGLT2 inhibitor. And these medicines can be up-titrated simultaneously. This was an analysis that looked at patients at age 50 years. If they got conventional therapy as compared to this new comprehensive therapy, you would expect about 8 years of life earned in that population, which is pretty significant. I do want to mention that calcium channel blocking drugs are not recommended as first-line treatment in patients with HFrEF, as are non-steroidal drugs. We try to stay away from those. And then again, if our patients remain refractory symptoms despite everything we could do, we really should think about palliative care or evaluation for transplant or left ventricular assist device. And this is really where your heart failure specialist can help you navigate these waters. Advanced options are available, but they're not right for everyone. And so we can help weed through those muddy waters sometimes. We talk about sodium restriction. The guidelines would say 1,500 milligrams a day are reasonable for most patients. However, once you get to stage C and D, there's really insufficient data to recommend any specific level, but less than 3 grams is reasonable. There's really no data that supports routine strict fluid restriction in heart failure patients, so we don't recommend that in general. And then cardiac rehab for our HFrEF patients is recommended and covered by most insurers. When we get to HFpEF, the chart's much smaller because we really focus on symptom control by controlling blood pressure, diuretics for volume overload, and then the only class of medication that's been proven to show benefit is mineralocorticoid antagonist again, and that's reduction in hospitalizations. In the Paragon trial, which looked at patients with a higher ejection fraction with the ARNI, in that group between 40 and 50, we did see trends towards benefit. And as the ejection fraction became better or closer to normal, that benefit tended to go away. So there'll probably be more to come from this in the future. So in conclusion, heart failure is a clinical diagnosis as well as a progressive disorder. As we're seeing these patients, we should avoid clinical inertia and try to optimize guideline medical therapy for HFrEF with guideline-directed beta blockers, ARNI, mineralocorticoid antagonists, and now SGLT2 inhibitors. And if you need additional help, you should refer to centers with expertise in heart failure. Thank you very much. My name is Allison Bailey, and I'd be happy to answer any questions by email, or you can tweet me. Thank you.